Congrats on making it this far. I'm Ishita Moghe, as you hopefully know, and the name of my talk is The Technological Revolution in Medicine. So I know that on the course schedule, I was going to talk about medicine before medical school, and it is still a part of my talk, but I was pretty excited to talk about all of the other advancements that are, I think, very close to us right now. And they're very, I think a lot of the things that we've been talking about in this course, we've been talking about it in very long term. So today I wanted to talk about some of the things that are already in practice using AI in medicine, and not just AI, but other technology as well. So first I'll talk about medicine before medical school. So we have a poster, Dr. Souls and I, talking about this topic that we've presented at a few conferences. And a lot of the things, the comments and questions we get is how it's possible that a student or a trainee can be expected to learn such high levels of medicine before actually going to medical school, which is what I'm attempting right now. If you already know, I'm working for a year with Dr. Soles in renal pathology. And I'm just like you, I just finished my bachelor's this July. So when we're talking about teaching students medicine before actually going to medical school, we have to realize that it's not the actual medical skills that we're looking for. So a survey of both American and European physicians said that these are the top 4 things they were looking for in their incoming medical students: good study skills, factual retention, conscientiousness, and emotional stability. So obviously, these are things that aren't age dependent. In Europe, most medical students start straight after high school, whereas in North America, we have to do 4 years of our bachelor's first. So if we look at these things, we can see that they're very applicable. They can be found in students before they actually begin their formal training. So an issue that faces specialties like pathology is that it's having trouble recruiting new young trainees coming in. And a reason for this could be that many students, especially in North America, where we're about 21 before we actually enter medical school, already have an idea of what specialty they're interested in. Lots of med schools actually ask on the application what potential specialty we might be interested in pursuing in the future. And when subjects like pathology are introduced in the late second year and students have to pick a specialty at the beginning of third year, we can see that there are a lot of specialties that aren't as likely to be chosen just because students haven't had exposure to them for the past few years. So this isn't just specific to pathology, that's just what I'm doing. But specialties with trainee shortages also include surgical specialties like neurosurgery and vascular surgery, and also primary care such as psychiatry. This is in North America. So we can see that exposure to a specialized field, including the basic science within it, can increase and improve recruitment rates to struggling specialties. And this would benefit both the educator and the trainee. So this is just a quick recap of what I'm doing in case you're curious, but what I'm doing is nephrology immersion. So nephrology is the study of kidneys, the kidney disease and healthy kidneys. So my role includes examining diagnostic imaging, photographing slides, assembling and presenting cases at rounds, so cases that are coming into the hospital. And also, recently, I've also been training new residents and fellows. So here we have a graph from the Association of American Medical Colleges. So there's a huge deficit of physicians coming in for all specialties, but this deficit increases drastically when we're looking at specific specialties that are having recruitment issues. So I think doing immersive training, and also doing research with students before they enter medical school, which has the potential to greatly improve these issues. So I'll go into the second part of my talk now, which is medicine and technology. So the question is, why now? And if you remember Dr. Osmar Zayan's presentation, he mentioned that there were 3 major reasons why all of this technological advancement is kind of culminating and presenting so many new opportunities right now. So the first one was the development of powerful new algorithms. The second one was huge amounts of computing power. And then the third one was the availability of large amounts of big data. So we'll start by talking about big data. So big data is essentially huge amounts of data that we can't process in the traditional methods. So to kind of illustrate just how much we have, here is an exponential graph which says by 2020, which is only 2 years from now, not even, well, yeah, 1.5, there's going to be 50,000 billions of gigabytes, which is a massive amount of data, and most of it, the orange part, is unstructured. So we need to come up with computing mechanisms to kind of deal and cope with and sort through this huge amount of incoming data. So this correlates with an explosion in our computing power too. So this is just an example of cell sequencing. So the blue line is Moore's law, which you've seen a few times already. And the orange one is the cost of sequencing. So at this point, this hasn't gotten to 2018 yet, but as of now, we're able to sequence cells for a couple cents per cell, and we can do millions of cells at a time. So let's look at an example of how big data and big computing are being applied in medicine today. So there's this study from last year, which is looking at kidney transplant survival rates. So organ transplant, many times it faces failure and can affect the survival rates of the patients in which it's transplanted. So this study looked at 3 hospitals in Korea over a period of 15 years and looked at all of the data of the patient and the kidney donor and tried to figure out factors of the data that could let physicians know prior to transplantation what the success rate of the transplant can be. So obviously they took a huge amount of risk factors. This is just a few. And I wanted to illustrate that each of these factors is in binary, coded for the machine learning algorithm. So if you actually look at them, if you actually look at the factors, it might not seem like very many, like age, sex, BMI, and then disease, lifestyle, blood type. But if you actually code each factor in binary, it's a huge amount of data. So this is one of the charts that was in the paper. And in the end, they collected over 50 attributes per person for 3,117 total donors and recipients. So it's a massive amount of data that needed to be sorted through. So these researchers applied a whole bunch of machine learning methods, and they actually got good results. They figured out that acute rejection, acute rejection, which is within the first year, is related to the serum creatinine levels at 3 months. So this is a pretty big finding that can be applied. So if we can figure out what the probability of transplant failure or rejection is before the actual transplant, this can drastically improve the actual survival rates of the patients. So this is just one example. So another answer to the why now question is you've probably heard of precision medicine. It's kind of a buzzword in healthcare right now. But our traditional model of medicine, what we do now is that we have patients, when they come in, we look at their symptoms, their clinical history, compare it with our previous patients, and then we figure out a way to treat them. What precision medicine wants to do is take each patient individually and look at their actual genetic data. So genes, proteins, disease mechanisms within each specific individual, and compare that to a massive data set of previous individuals, and then come up with personalized treatment for each person. So obviously this is kind of far away, but we are definitely making strides towards it. So now we'll move on to AI in medicine. So how we're actually starting to apply these huge amounts of data to treatment. So here's a kind of sad infographic. So it says 54% of doctors say they're burnt out, 88% of doctors are moderately to severely stressed, and 59% of doctors wouldn't recommend a medical career to their children. So this obviously isn't very great, especially when we compare it to the physician shortage that we saw earlier. So we'll look at how AI can potentially help to improve these statistics by acting as an aid to physicians. So here's my first example. So we've talked about digital pathology a few times in this course, but just to recap, what digital pathology is referring to is that a lot of times when we take biopsies, we take a tissue sample from deceased organs, we cut it up into thin slices and stain it, so it's on physical glass slides, which aren't the most convenient since they can fade. We have to store huge amounts of them. And also, if we want to collaborate with people in looking at these slides, we have to actually physically mail them instead of being able to send it to them digitally. So digital pathology refers to the actual digitization of these slides into computer images. So in terms of digital pathology and computer-assisted diagnosis, there's been a lot of research recently in using computer programs to analyze these slides. So it's been found that humans and machines make different mistakes, which works great in a complementary system where if both of these are working together on a slide, they can catch each other's mistakes. And computers are also able to examine subvisual features that human pathologists can't catch. And this could also reduce workload by having fewer work hours and increasing the efficiency. So an example study of this is breast cancer metastasis in lymph nodes. So this study used a deep learning algorithm and 6 pathologists. So the algorithm went through slides and identified areas with high likelihood of containing a tumor. So it's computer-assisted diagnosis because the computer is not actually making a clear-cut definitive answer of this part is diseased, this part is not diseased. It's mostly at this point just looking at areas that are suspicious, that may have an issue that don't look completely normal, so that the pathologist can go in and look specifically at those areas instead of spending much more time combing through the entire slide. So they found that for micrometastases, computer-assisted diagnosis improved sensitivity. So with the computer, they were 91.2% accurate, and without the computer, pathologists were 83.3% accurate. So it's important to note that these are micrometastases because, as I said in the last slide, these are subvisual features. So I think the ability of these technologies to complement what pathologists already do could have a huge impact on both the care that patients receive and also the efficiency and burnout rates of physicians. So here's another technology that has been already applied, you've probably heard of IBM Watson. So IBM Watson for Oncology launched a basically computer-assisted diagnosis program in which physicians would enter cancer patients' clinical histories, their presentations, their symptoms, and this program would respond with treatment methods with a list of most likely to work to least likely to work. And unfortunately, this didn't really go as planned. It was pretty well publicized that it failed, but it is still in the works, like it's still being enhanced and developed. So I just wanted to kind of point out that these things aren't just theoretical. These are actually being applied today in real hospitals with real patients. So let's move on to the machine learning part. So we know that we have this big data. Now we have to figure out how to create these powerful algorithms to deal with this big data. So this is a slide from Dr. Zayan. So if you remember, he mentioned that we have to have huge amounts of labeled training sets in order to actually train these classification models. So the issue that a lot of people are facing is actually the production of these massive training sets that have to be expertly labeled. So a lot of recent research has been looking at crowdsourcing as a source for all of this labeled data. So we're looking at crowdsourced expert annotators and programmers. So can you guys think of any demographic, any group of people in the world, not necessarily in healthcare, that spend huge amounts of time on the computer developing a really specific skill in a really specific situation? Can you think of any group of people that do that voluntarily?
Computer scientists.
Well, yes, computer scientists, but they get paid for it.
Yeah.
People that play video games?
Yeah, people that play video games, yeah. Gamers. So a lot of research has been looking at harnessing the huge amount of power that gamers have and actually creating data sets with it. Since this is a pretty big group of people that are already voluntarily spending hours of their time on the computer developing really specific skills, right? So the motivation for getting these people to actually help in medical image classification, which doesn't sound that exciting, is gamification. So gamification is the application of game design elements and principles in non-game contexts. So one of the most popular types of gamification is called PBL, which is points, badges, and leaderboards. So these things, even if you're not getting real physical rewards, it's been shown that having just points, badges, and leaderboards is actually a huge motivator for people to take part in things. So there's this study from 2014 which showed that gamers would voluntarily spend a lot of time labeling cells and slides just by breaking it down into tiny parts. So although deep learning requires expert annotated data, this study said that by using a huge amount of data and aggregating it by non-experts, it can create the same effect. So I wanted to do a little experiment with you guys. So this is an image from a kidney biopsy, which is what myself and Dr. Solas and Majid look at. So all you need to know here is that this is a glomerulus in this circle, and everything outside is interstitium. That's the only thing you need to know. Oh, and also this is normal. And now this is what we're going to be looking at. So I'm going to give you a series of statements that can be answered true or false. So you only have two options. So the glomerulus looks normal. Would you say true or false? The glomerulus is this part.
Say false.
False?
I think false.
Okay, yes, you are correct. So there are visibly darker areas or mass.
True.
True? All right. I think this is the last question. Dark area forms a crescent shape. True?
Yeah.
Oh, sorry. He already said true. This is the crescent shape because I thought there would be people who are objecting. So, but this obviously is a very simplified way of doing it. But it shows that you've probably not seen this before. But if I break it down and ask you pretty simple questions, you can help with the diagnosis of certain things. So you wouldn't actually give this diagnosis, but if you highlighted this as not being normal, then someone like Dr. Soles wouldn't have to spend a whole lot of time looking at every single glomerulus in the slide. He could just look at the specific ones that were tagged. So yeah, so those questions were really simple, but the study that I was looking at, I feel the questions were actually even more simple. They asked, all cells are of identical size, all cells are of identical shape, how many cells are there, do they have the same texture, and are they arranged orderly with equal distances to each other? So you can see how literally anyone can do these, right? As long as you have that picture in front of you and you can look at it. So the results of this study were that experts were more accurate than non-experts, obviously, but preliminary assessment by non-experts plus in-depth analysis by experts increased the efficiency and accuracy. So I think it's really important to have both of these, because if it was just efficiency, it might not be worth it to spend all this time recruiting other people, but it also improved the accuracy. So we're talking about actual patient data and patient healthcare being improved. So here's another example. This one's using an actual video game. So these researchers inserted an image classification mini game or side quest directly into a commercial video game called EVE Online. So they obtained 33 million classifications from over 300,000 gamers in 1 year. And this data was successful in teaching and improving a deep learning cell annotation algorithm. So this didn't even use experts at all. This just used data from gamers who probably hadn't spent a lot of time looking at cells beforehand. So the previous things were just talking about coming up with training sets for algorithms. But crowdsourcing can also be used to come up with actual algorithms. So there's a few websites where they offer prize money, organizations offer prize money to programmers and computer scientists to come up with specific algorithms for whatever project they're working on. It's not just limited to biology or medicine. Like, there's lots of businesses doing it, like Google and Facebook have done it. So here again, we can see how using game principles can really motivate people who are not involved in the field to come up with solutions that are applicable in medicine. This one's, I took these pictures like yesterday, so this contest is actually still going on if anyone wants to participate. But so you can see how they offer huge amounts of money, and they also, the website is called Kaggle, but they also use the same gamification elements that we look for in a lot of the games that we play just for fun. So there's points, leaderboards, badges. So, and you can, these are continuously updated, so you can keep seeing if anyone's beating you and like what their score is and things like that. So I know I've talked about a lot of things, so I just wanted to do a quick recap slide. So a lot of the new methods that we've talked about so far, digital pathology, single cell sequencing, they produce big data. So massive slides, images, huge amounts of single cell data, patient data. And it's difficult to do anything with these, to come up with an actual course of action with just this big data. So we kind of insert all of that big data into machine learning. And the actual machine learning itself is complemented by gamification and crowdsourcing. And the machine learning can output actionable data, so computer-assisted diagnosis, data analysis, and even treatment. So one of the other things I wanted to talk about that's not necessarily involving AI, but is more bioengineering, because I think we've kind of talked about this a few times in the course, like we've talked about designer babies and things like that, but we haven't got into detail. And this is another one of those things where we're looking at it as if it's very far off, but I don't think it's that far off, since these things are being applied in humans today, but I'll show you. So here we've got, the first thing I wanted to talk about is induced pluripotent stem cells. So if you haven't heard of these, we've always known about stem cells and pluripotent stem cells, but previous research needed to get these stem cells from actual embryos. So we would need actual human embryonic stem cells, which are kind of difficult to obtain. So we then found a technique to take adult cells, just normal adult cells, and turn them into pluripotent stem cells just by inserting 4 embryonic transcription factors. The next challenge was that obtaining these human cells was invasive. You had to probably get them from inside the body. And then we found that we can now generate these from urine samples. So it's extremely non-invasive. They can, I think the paper said you only need 30 mils of human urine. And then you can get exfoliated kidney cells from that urine, then apply these transcription factors, and within 5 to 6 weeks you have functioning pluripotent stem cells. And the exciting thing is these are specific to that individual. So these have your genes, your proteins, all of your epigenetics in that. So, and stem cells, obviously, you can turn them, you can mature them into any other kind of cell, right? So an application that has been developed already is that in macular degeneration, we can we can produce retinal cells to fix this. In the future, these things haven't happened yet, but we can imagine that because Parkinson's people lack dopamine-producing cells, we can use these to produce these. It can also be applied to diabetes, where we can create insulin-producing cells. So obviously this has really far-reaching consequences in that it can actually come up with ways to not only prevent, but possibly cure these really massive, widespread diseases. So another application which is currently in use is disease modeling. So if we grow a culture of your specific cells, we can apply different treatments to it, to that culture, and see if it responds. So rather than treating patients and then waiting for them to see if it works or not, and then if it doesn't work, applying a different treatment and then seeing if that works, we can just do it on the actual cell cultures and then see if it responds, so that when we actually treat a patient, we'll know for sure that this works with their genetic makeup. So the second bioengineering tool that I want to talk about is the CRISPR-Cas9 gene editing. So you've probably heard of it. It's very specific and efficient. It's currently used with extremely high success rates in mouse embryo gene editing. And recently it was also applied to in vivo gene editing to treat muscular dystrophy in dogs. So this is a huge deal, especially the in vivo and dogs part. So rather than altering gene sequences outside in a lab in a test tube and then injecting those into someone or an animal. In vivo gene editing would be to take a live organism and put these specific gene editing things into that person and actually see how it affects that organism while it's alive. And I think applying it to dogs is a huge step forward from mice, because while mice are good model organisms, there's still a huge level of complexity that's missing from mice that we have to go through before we start applying it to humans. So in this study, they actually treated the muscular dystrophy and saw huge improvements. It wasn't extremely long-term, so while it did cure muscular dystrophy in dogs, we're not sure if this would last for the lifetime of the dog, but obviously it's a huge step forward. So CRISPR has also been applied to human embryos. Obviously they were fertilized but non-viable. They weren't actually implanted, and no one actually gave birth to these embryos. But in a study, embryos had a heterozygous paternal mutation. So their maternal gene was normal or wild type, and their paternal one was mutated. And these researchers induced double-strand breaks using this system, and they repaired the mutated gene. So they actually turned heterozygous mutated embryos to homozygous wild-type embryos. So this is obviously very impressive. And CRISPR in human embryos, these research studies have been going on. There's quite a few from China. There's some from Europe too. And it's also raising a lot of ethical questions, obviously, because we don't have any kind of legal regulation in place for this. And since it is a very slow process for legal regulations to catch up, I imagine we won't have them for a few years. So it's interesting to think about the implications of having to have these laws catch up to the technology rather than being prepared for it. So for my conclusion and discussion, a lot of times we look at AI as being scary or as a challenge for physicians' jobs or anyone's jobs. So I wanted to put this up here, that 12.9 million people will have a shortage of 12.9 million people in global healthcare workers by 2035. So this doesn't just include physicians, but obviously nurses, all sorts of healthcare workers. But we can see how using AI assistance or mechanisms, or even things that previous lecturers were talking about, such as having little robots or little robotic dogs to keep seniors company or to check up on the health of them. It can be a huge benefit and not necessarily a threat to the jobs of healthcare workers. So my conclusion is that machine learning is already being used in medicine today with mixed results. So while there have been some aspects that are doing really well, there are some aspects that have failed, but they're continuing to improve at a really rapid rate. And in the long term, it is undeniable that computer-assisted diagnosis and bioengineering in humans are very real possibilities. And I put a question mark next to long term because I don't know how long term it really is. I doubt that the possibility for designer babies would be real and achievable by the time people our age start having children, but maybe by the time our children start having children, it would be an actual possibility. So it's really not that far. I expect it's within our lifetime, but so it's not as long term as we make it out to be. And one of the other things I wanted to talk about, this is a simplified version of the chart I showed you before, that big data goes through machine learning to produce actionable data. But the issue we have to keep in mind here is that before we actually feed that big data, huge amounts of personal patient information to computer programs, we need to have the proper federation and regulation in place. It is very easy to de-anonymize data. So even though we feed programs anonymized data, it's quite simple to track down specific patient information from it. So although we've already started this process, I think it's really important to go there first. I don't know if it will happen in time since it's already being applied, but I think it's definitely something we need to keep in mind. So the two main things I wanted to discuss with you in the time we have left today. Oh gosh, okay. Okay, so the two things I wanted to discuss are firstly, the regulation and protection of our data. Would you individually be willing to share more data if you think that it can improve our healthcare system? Because I know that me personally, I'm a bit skeptical about those organizations like, oh, I don't remember their names, but they do the genetic sequencing. You like give them a swab of your cheek or something, and then they do your gene sequencing. I think it's cool. I know lots of people that have done it, and they've found out cool lineage things about themselves, but I'm a bit skeptical about giving a corporation my actual genetic data. So I wanted to hear your thoughts about that. And the second thing I wanted to talk about is how far is too far in terms of modifying our health. So the consensus so far from what I've read, there's no formal consensus yet, is that human embryonic genetic editing could be okay in terms of fatal, life-threatening diseases. So this is really difficult to understand because then the next step is to ask, is it okay if it's not fatal, but a very debilitating mental or physical handicap? And then we ask, what if it's not that debilitating, but it's pretty bad? And then it can go pretty quickly into just enhancing our normal healthy children, right? So yeah, those are the two main things I wanted to hear your thoughts on. But thank you for listening. I liked last class's idea of going around in a circle so everyone has to talk. So does anyone want to start, or are we just going to start over here?
Yeah, just love sitting here. Which one are we starting with?
Let's start with the first one, regulating and protecting, and if you as a patient would be willing to give huge amounts of personal information.
I think I would, because it's staying, I guess, or you have the expectation that staying in the medical field and helping, cure diseases and stuff. So I think personally, I wouldn't have looked that far into it to think that I could be used for other things. I'd probably be fine giving it up.
Okay. But how do you know someone outside of the medical field might not take advantage of it?
I guess it's like a possibility, but
you're trusting that it'll.
Yeah, trusting that it'll be something that, because even right now we have all the, like a lot of information on the, I forget what it's called, the big system over the internet where they keep like all the medical files and stuff, but you have that expectation is going to stay kind of within that field.
Okay. Do you want to go?
And as a matter of fact, in 2012, when I was staying for a while in the US, I'm done with this sequence and I'm active with the company for this issue because, as you know, there are many years and there are famous genetic banks for the recording of any vital, gene issue, gene pattern. So it's a kind of, you know, a great, great library, and so fascinating. As far as there should be regulation, international regulation, I assume, for the protection and for the, you know, observation of the kind of this usage of this gene banking and information. And how far is too far in terms of modifying our health? As Dr. Solis mentioned, the identity crisis is one of the most issue for everyone, I guess. Especially for the some, you know, future pattern of colonization of humankind and something like this. Identity crisis means describing an individual for the future is most, I think, is the major issue.
Okay.
In terms of sharing information, I think those corporations must have some kind of a guidelines on how they're going to use that information. So it should be regulated so that the corporations are using that information not beyond the medical level, so not disclosing other personal information, like other background information that might not necessarily be relevant to the research area.
Mm-hmm.
I think the patient information and the data are already being shared to a large extent in medicine right now. Even like when you're doing blood donations, your information is like kind of getting shared by everyone. And I think the advancements that we have right now in the medical fields are kind of based on previous patient data and different case reports. So I think the patients, I think they should be comfortable sharing their data when it's already kind of open in the field right now. So I'd be willing to share my information if it's used safely and.
Okay.
Yeah.
You're on.
Okay, so I was thinking that I personally would be okay with sharing data, mostly just because it would be exciting to hear like maybe the new things that we can learn from genotyping or understanding our genetic characteristics. Same time, in a more selfish reason, it would be nice to see if there's something specific to me that they learned, and maybe certain things I didn't know about myself, and that would be pretty exciting to hear.
I have some reservations. I think I have some trust issues with the larger system.
Mm-hmm.
Ideally, I would just want to know that there is some professional in my corner that is somehow attentive to all of this information. I worry about where it might end up. But if persuaded that it was safe, I would be willing to share if I thought it was truly going to help the gaining new information.
Okay. I was waiting for someone to be skeptical. Everyone seems so willing to give up their information.
Yeah. So, I would look at two situations, Canada now and China in 2022. So, like Canada now, I would feel comfortable sharing information. But think about China in 2022 when they planned that every citizen and maybe every contact person will have a score of loyalty and this kind of thing. Could also be a health score and all sorts of other things. And so it is a bit scary to me that the country that I'm living in might be grading me based on data that I voluntarily submit and might make choices about me. I mean, they're saying that behavior-wise, if you break a lot of laws and stuff, that you won't exactly be in jail, but like anything you want to do, you'll find that it's actually not possible for you, that all your friends can do it, but you can't, you know? Stuff. So, and what about other countries? Will they be more like China in 2022 or more like Canada in 2018? I think we don't really know how popular this grading of citizens and mass surveillance kind of thing, and feeling that you can control everybody by rewarding the qualities that you want and you know, giving them penalty points for the things that you don't want. And would it all be voluntary things, or would some of it be genetic things, ethnic things, you know, that if you come from a Muslim community, you automatically get scores, points removed, you know? I mean, it just, you'd have to think about the overall context of the society in which you're living. And there might be some societies where there'd be a whole bunch of people sort of hiding out to avoid their DNA being analyzed, right? Like they're like in their own kind of underground societies to prevent being surveilled. So, like the three questions really assume living in Canada, and that, you know, Canada remains kind of the way it is now, that like kind of Western civilization at its best. It's just a little bit boring because we don't start wars and we don't, like, we're not, you know, aggressive, right? So it's a pretty good place to live. It can make you more comfortable releasing information about yourself than if you lived almost anywhere else in the world. Even, you know, the US, you could imagine that the average US citizen might be, in the present climate, much more hesitant about releasing information about themselves because of the polarization of US society now. So I think these questions need to be considered in a context, I guess. That's what I think about it. So some of the earlier parts of the talk that really interested me, the gamification, it may initially appear to you that only young people would be interested in this. So in fact, I've known that like more people play video games than don't, and it's more successful than other kinds of entertainment. But I had never actually played a video game until like a few weeks ago. And then there's this everything game it's a video game with Alan Watts quotations and, you know, philosophy and inserted in it. So it's like taking the culture of the 1960s and 70s and making a video game out of it. And the cool thing about Alan Watts' quotes is that his whole family, even though he's been dead for like a quarter of a century, his whole family still supports themselves through, you know, one of them is responsible for his movies, another for his audio quotes, and so on. And he's basically keeping the whole family going financially through this stuff that he did when he was alive. So what is going to be a problem is this conflict between, it's exactly as, Ishita said, that AI can make the job of physicians easier and better, right? But AI is also the primary source of burnout and frustration. Like primary care physicians today working like 11-hour days, 5 hours seeing patients and 6 hours typing and entering data into computer. And you can imagine that with voice activation, maybe things will be better, but the patients might complain then that they go to see the doctor, they're always mumbling. They're mumbling to the blah, 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 blah. That might also not be a terribly popular thing. Right now, patients feel the doctor's distracted when they're entering data into computers, but that digitization, just as Ishita says, is the critical step. Nothing AI-based can occur if you don't have digitized data. You have to have that. So how are you going to incentivize people to enter the data? And I think gamification, even for people who've never played video games before, playing video games is fun even if you have not previously done it. So it's not just for young people. It is potentially a way, and just one of multiple ways we need to find, to make data entry fun, right? That we're kind of desperate to make it fun, so that physicians who have to do a lot of data entry during the day don't feel burned out, don't feel frustrated. And this is a very real problem right now. So one of the other things I think that it is apparent when you listen to this presentation is there are some really important ideas here that are really simple, like the idea that we are not going to get anywhere trying to give in to people who say, I don't want to have to enter data on a keyboard. I want to practice medicine without that. So there's a few simple things here. That's not possible. It is impossible. You can't say, okay, well, you don't want to do it. There are kind of trajectories and a kind of momentum of certain things that are inevitable, and that includes digitizing healthcare information. So rather than just complaining about physicians who don't like it, we have to find ways to make it more palatable, more interesting, more enjoyable, or think of other ways to do it, like with voice, gestures. Gestures are sort of limited. If you think of the gestures you use on a computing screen, you can do a few things, but it's not like complete sign language or anything, right? But maybe there's something beyond that. There's something we haven't thought about, a way to more seamlessly communicate that's fun and intuitive and that people will actually enjoy. And somehow, video games that have become kind of addictive for a large number of human beings, I think they're kind of potentially onto something that could help with some of this, make it more fun. Like surgeons, I was kind of intrigued with the idea of surgery immersion. Like how would one do that? Well, you wouldn't let an undergraduate who hadn't been to medical school actually operate on human patients, right? But they could learn about it, or they could do simulated surgery, right? So, but surgeons in training now, the ones who've played video games as kids, are naturally more skilled. This has been shown over and over again. So like when you were a kid and you were playing video games, you didn't know you were partially training yourself as a surgeon, but you were, you see.
Operation.
Yes, and if you did a lot of it, you're almost there, you know. So these are, like, you can think that a lot of these questions and problems are like complicated and kind of obtuse, but a lot of them are very simple and very important. And they're not things for the future, they're now. Like they're, just as Ishita said, the burnout rates are very, very high. They're much higher in the US than in Canada. Why? Because the electronic medical record has been forced on people in very effective ways. It's those sort of carrot and stick. They used the carrot first, so they would reward people, they would reward hospitals that would embrace the electronic medical record, make sure all their staff were using it. And then that went on for a few years, and then they started to penalize the ones that weren't doing it, and then the rest of the hospitals fell into line. So the number of hospitals that are completely using the electronic medical record is much higher in the US than it is in Canada. We have this, you know, democracy thing going on in Canada, and we're polite to each other and so on. And that's not so much a thing in the US, and so there are many more burned out physicians there. So we're behind them, but maybe we can do it better. We can find a way to get this digitized medical data going without burning everybody out, without making physicians feel that they would never recommend this career to anybody else and so on. I was kind of shocked in my medical school, medical student teaching this year, there was a new observation made that the students found a kind of optimism in my teaching that they weren't getting from the other people. I said, "You're not getting it from the other people?" They said, "No, your idea that medicine is so vast and heterogeneous that, you know, everybody can find a place and you can sort of make the world your oyster there," and, you know, which is kind of how I felt. Nothing has ever happened to dissuade me from that idea. But I have the impression, you know, there are like 600 full-time faculty members, 600 something in the Faculty of Medicine. Only about 20% of them directly do small group teaching. And it seems now like half of them maybe is showing some burnout tendencies where they're not that, you know, optimistic. And they also see something wrong with just being young, that like, yeah, you know, they don't that much enjoy being with young people, and they don't that much enjoy medicine. So, yeah. So, and this is the first year that I've felt that the students felt that optimism about medicine was a really unusual thing that I had that most people don't have. And I'm pretty sure that was not true in general in the past. So we're really, although this course is about the future, these issues are really about right now. You know, the hospital is putting in a new information system. It's one of the largest outlays of cash that the healthcare system has, you know, invested in the history of the province. And just this morning, this team of women went from room to room to get the computer numbers of the people and so on. We're close to, you know, implementation of this. They sort of, they don't exactly march like a military force, but when they enter your room, suddenly you realize if there's a fire, you're gonna be toast, because this large group of ladies stands between you and the outside world, you know? So it's a really dynamic situation now, and it's happening in this province, in this hospital. You know, there's a lot of consequential stuff related to this lecture that is going on all around you right now. And the next time you see a doctor in the hall, pay attention to whether they look happy or not. My impression is that they used to be mostly happy. They would smile and greet you and so on. And it's important if the average physician face you see looks disgruntled and out of sorts, right? That's not a good thing. And it's not a problem without solution. There would be solutions, right? And they may need innovation, but that's part of the reason that you took this course, is that you were interested in kind of innovative stuff. Yeah. So I just wanted you to feel that the immediacy of the issues that Ishita talked about. These are not things that are just in the future, or that you won't face, or that the people around you don't encounter. These are things from the here and now, and they're really important, and we don't have all the answers, and you could help contribute to that. So other comments? We have 12 minutes.
Are you guys interested in talking about the human gene editing? Any thoughts?
So thinking about simple things, the first time that goes badly wrong, that you take a child who was destined to be sort of ordinary, but maybe had a hair color different from what the parents wanted or something, and they thought that's what they were changing, and they ended up with some huge life-threatening, abnormality. It's that kind of crisis that would lead to all sorts of regulations and so on. And it's kind of accidental whether really spectacularly good things happen first or bad, right? It could go either way, and that will affect a lot of things. You remember cloning of sheep, right? Dolly the sheep, yeah. Well, that didn't turn out all that well for the sheep. It doesn't mean that it doesn't work in the long run, but it was interesting when you look at the excitement surrounding Dolly the sheep, and the fact that we're not really using that technology today.
As far as I'm concerned about this issue, for example, in India, nowadays suffered a lot because this genetic manipulation for making more men and women, and resulted in a kind of social problem.
Yeah. No, that's right. So that when you can identify sex before birth, there are a number of societies that end up with it is economically more beneficial to have a male child, and yeah, it's obviously that's maybe the most long-standing problem of this nature. Yeah.
I just want to say that's the perfect example of a problem where if it's just left to the whims of individuals making decisions for themselves without any regard for the mass effect of it, and that's how you end up with 100 million more males than females in certain countries. So I think it indicates that while we'd love for individuals to be able to make decisions, there will be some decisions that have not just loose but really direct societal outcomes, which might mean that as we go forward we have to look at ways of placing limits on human autonomy for the greater good. It's hard to imagine how that's going to go down in certain societies and among lots of individuals.
Yeah. So, you can also think of the role of the cheerleader, right? So I know that may sound to you like a ridiculous thing to think about, but in science and in society in general now, we need to get people excited about things that they're not currently excited about. And it's not unlike what cheerleaders or cheer people do at sport games. It just, I think that we need to think of every conceivable way to get people to be really enthusiastic about digitizing health data, it's at all levels. It's not just, physicians, nurses, and other health professionals are also complaining about this now. Yeah.
If you have a chance to win a car by inputting your data, I think that might help.
Yeah, no, that's right. Like you can think of the digital data input X Prize, right? So, the X Prize, these huge prizes for like the self-driving car and private space flight and so on have been really successful. But that model doesn't work very well when you need a large number of people to do something relatively small, because it doesn't scale in that sense. It works better if society benefits if one person's the winner and or maybe 2 or 3 people getting these huge prizes, and then other people can build on the success of what those 1 or 2 or 3 people have done. But it doesn't mean that it's not worth thinking about. There has to be an innovative way to get people's endorphins flowing while they're doing new things they haven't done before, that make novel circumstances that benefit society fun somehow, rather than making them unpleasant and tedious and something people complain about. And they socialize by getting together with other complaining people, and this amplification of the complaining makes them all feel less good at the end of the day, and so on.
Or the approach of the Brave New World, like the famous dystopian novels, where if you can't get the endorphins going externally, you just pump them in,
right,
and create the feelings within the people, manipulate them further that way.
Yeah, but in the long run, that doesn't work. I don't know. It's hard to know. But I'm having a job interview for something related to this on the 7th of December, so maybe I'll know more after that. Anyway, so yeah.
I mean, just so much of this comes down to the system.
Yeah.
I mean, we can think about what we want to do, but we realize we have to operate within the world as it is, and that it pushes us in certain directions. So even the whole electronic health record, as I'm listening to today's discussion, thinking, what's really the motivation? Is it that there are people who think this is going to drastically improve health? Or is it just a bunch of people who have been persuaded that that's a possibility? Because when you see the price tags that are not just $1 million, but $1 billion for these systems, and combine that with, are the doctors unhappy and are the patients unhappy, it means that I think that the beginning of these discussions has to look at the system. Have we created the structure of a system that's going to enable the right thing to get done?
Yeah, well, I think it'll be easy to figure that out. There's lots of obvious flaws in electronic healthcare systems of the past. I mean, that are really obvious, that communication mechanisms like leaving voicemail that you never use in your personal life because they're too clunky and everything else is faster, are, you know, the mainstream, the way physicians in that old system communicated, you know. And there are many things like that. Just knowing who is responsible for a given patient. You would think it'd be simple, particularly in 2018 that would be simple, but we still have the situation, and I think it's not just us. So just looking at kidney physicians and kidney pathologists, we never know who is taking care of a given patient at a given time, and they never know which of us is reading the kidney biopsies. It seems so simple, but then you just multiply that for every service in the hospital. Wouldn't it be better if at least the system knew exactly who was doing what? So maybe you don't need to know, you just say, I want to communicate with the person caring for, you know, the renal medicine aspects of this patient's care at the moment, and you'd be instantly somehow able to, you know, communicate with that person. And that deficiency in the current system, which seems so simple, is just one of hundreds of things. You know, if you look at the fact that the different systems don't talk to each other and everything. So the fact that our new electronic medical record system is so expensive presumably means it will fix all these things. Or if not, maybe by that time people will have forgotten what the original reasons were. They just want to see it. They've all now been trained on it, and people have been talking about it for years, so they just want to see it happen. But anyway, I hope that all these improvements do take place and that the billions are well spent. The first large introduction session where this new system was introduced to the physicians at the hospital, the IT professionals were convinced that this would mean a lot of job loss for them, this centralized system for the whole province. So the IT support people were sort of wrecking every aspect of this presentation to the entire medical staff. And I mean, that was also a kind of spectacular thing. So yeah, anyway. So it's 3:20. So next week and the week after we have the student presentations, 27th, 29th, 4th, and the 6th. I'm looking forward to that very much. And yeah, thank you for coming today. Okay, that's it. Yeah.
I also wanted to say, if you guys have any questions or want a review or anything of your presentation or papers, you can feel free to email me.